Welcome to the World Extreme Medicine podcast with myself, Owen Walker. In this session, we're going to be examining sudden cold water immersion with Ben Watts and Jamie Pattison. So what I want to do is speak to both Ben and Jamie, both WEM faculty and retrieval specialist practitioners, around the highlights and indeed dangers of sudden cold water immersion, and do a deep dive into some of the pathophysiological pathways that occur. So this is both in light of recent events, but also prospectively to promote a discussion around the very real danger of cold water immersion. So both Ben and Jamie have and indeed do work in the Highlands of Scotland, where temperatures frequently fall below zero. So welcome to the World Extreme Medicine podcast, Ben and Jamie.
Hello. How you doing, mate? Thank you for having us.
Good to see you. Absolute pleasure. So what we wanted to do is just try and revisit some of the principles and indeed some of the treatment pathways and look at the management of this condition. We do know that upon entry to water, some of the physiological changes that are evoked to the skin, nerves and muscles within limbs and indeed deep body tissues can result in hazardous outcomes. So I guess my question first to Jamie would be, could you outline some of the main problems around some cold water immersion that paediatrics or indeed adults face?
Yeah, of course. So for adults or children, entering the water is kind of a multifaceted problem. So cold water, and it doesn't really need to be that cold either in terms of, water freezes, etc., and there's ice everywhere and snow. You enter the water and it's cold enough and you're not acclimatized or acclimated or anything like that, you're going to have some pretty horrendous physiological responses where you get the kind of classic term of cold water shock, where you get inspiratory gasping and hyperventilation, which is the last thing you need to be doing when you enter the water, especially in an uncontrolled manner. The other big problem with that is that I think that a lot of people, and certainly I did until a few years ago, underestimate how dangerous the water actually is. So especially moving water and what we call swift water, the forces that you're exposed to very, very instantaneously when you enter the water, when you start looking at the physics of it all, like, it's a crazy amount of force that's exposed on your body. Even if you're trying to stand up or indeed you're trying to swim, if you don't have a good understanding of hydrology and how these forces are acting on you, like, it's going to be working against you the whole time, which makes surviving and makes getting yourself to being able to do something to get yourself to a place of safety even harder. All the while you're trying not to swallow liters and liters of water, and then probably not that long until you reach swim failure, where your muscles cool. You're probably ineffective swimming because it becomes even more ineffective, and then leading to probably being swept away or caught up on something as well.
So Ben, can we just look at what's happening on the physiological level, and just from the body's reaction, both indeed a gasp reaction and, as Jamie was saying, this possibility you can get acute swim failure?
Yeah, absolutely. So I think the first thing to talk about is the fact that the physiological responses that you get with cold water immersion is one of the reasons that lots of people take up cold water swimming as a pastime. So you have two main things that are kind of affecting your physiology. So the first one is if your head and face go under the water, that face, that when it becomes cold and wet, triggers your breath hold diving response. Okay. However, as you've already alluded to, your surface kind of cutaneous receptors are responding to the fact that they're being triggered, and these trigger two different systems. So your diving response triggers your parasympathetic system. So that's affecting your sinoatrial and your AV nodes. So that's essentially looking to slow down your heart. your cutaneous cold receptors, when that triggers the cold shock response, what you've then got is a sympathetic stimulation. So that's also affecting your SA and AV nodes, but also the myocardium to speed your heart up. So there's a paper from Tipton, so Mike Tipton, who's an expert in incredible amount of research over the last 20-30 years on cold water immersion. So this autonomic conflict, so the difference between your parasympathetic and your sympathetic nervous systems acting at the same time can cause arrhythmias. So that's one of the first things that is happening physiologically. So your heart is trying to simultaneously slow down and speed up because of two different systems being triggered within your body. Now, there are things that can obviously affect your susceptibility to this. So in terms of, if you have medications or you've taken drugs that affect your QT, if you have underlying health conditions, your ischemic heart disease, your myocardial hypertrophy, or if you have known kind of channelopathies, then that can obviously predispose you to having one or the other causing you more problems. So the other things that physiologically will be happening, in terms of your activation of the sympathetic nervous system, you're going to get peripheral vasoconstriction, you're going to get tachycardia, and with the gasp reflex, you're going to get hypocapnia, so potentially hyperventilating. You're going to blow off some of your carbon dioxide, and that's going to reduce your cerebral blood flow, potentially causing things like respiratory alkalosis down the line. So there's lots of things that are affecting your whole body negatively from different systems. Now, when we look historically at cold water immersion, and a lot of cold water immersion deaths have been recorded as drownings, but without actually having any water in their lungs. So, the likelihood is, and what's reported by Professor Tipton, is that that's probably due to a early arrhythmia. So it's not a primary drowning case, but it's a cold water exposure leading to a sudden fatal arrhythmia. Equally, you can have the stimulation of your cutaneous cold receptors. You have this change of your ventilation, you have panic, you can have swim failure, and all of these things can increase the likelihood of inhaling water. So when you do inhale water, obviously that is moving in the direction of drowning, and with drowning you can have death, you can have morbidity, and you can have no morbidity. So the cold water immersion itself is very different from drowning in cold water. It is the physiological processes that are happening to your body initially on entering the water. And I'm sure we'll go on to talk about it shortly, but the difference between having your head clear and having your head under the water, and potentially the transition from having your head clear, having a reduction in muscle kind of usefulness over time as you become cold, and then having swim failure and your head starting to move underwater, that changes the situation. It changes the survivability potentially of these sorts of exposures. So the take-home points are, if your head's out and someone has had a very cold water exposure and they have died, but they haven't ever had their head underwater, the likelihood is this is from an arrhythmia, it's from a change in their cardiac rhythm with potential for hypothermic insult in that. And And obviously, there are very specific guidelines on what we do for resuscitation of those hypothermic patients. In terms of your drowned patient, so the patient that's had their head underwater, whether that is an immediate or a down the line event, there's potential that that person's inhaled water. And again, that changes slightly what you want to do in terms of prioritizing your management of these patients. And I guess for us, that's the key of how we go on to manage them.
So looking at a few cases from practice and from sort of the wider literature and indeed sort of the wider world, really. So we've got the case of the Norwegian skier Anna Bagenholm. And Jamie, I think you know this case quite well. She had a +2 hour cardiac arrest. It was, again, everything that Ben was speaking to around, rather than a rapid, it would be a progressive hypothermia. I think she was trapped under the ice progressively. Had a ROSC post 2 hours or post +2 hours with good outcome. Could you maybe speak to, is this a rare case? Is it a fringe case? Or indeed, is there a good outcome for these kind of patients?
Yeah. So for a bit of background, Anna was a Swedish radiologist working in Norway at the time, doing a residency at the University Hospital of Northern Norway in Tromsø. Skiing after work and came down a run and essentially went through a hole in the ice after she fell over, I think. Kind of lost control, fell headfirst onto a layer of ice, and it was over a kind of a mountain stream which is running underneath the ice, kind of a bit of a waterfall, if you like. And she was on her back and obviously looking up. And her head and torso, as the kind of water hit her, head and torso got dragged under. The water filled her clothes up, and her kind of body became trapped in the ice with her skis kind of sticking out. I think it took her friends maybe 5, 6, 7 minutes of like trying to pull her out and trying to rescue her before they called for rescue teams, which I think certainly any of us would be in that position of trying to self-rescue. I think self-rescue and bystander action is probably one of the most effective forms of rescue, certainly when we're talking about resuscitation. And then, so as they try to free her and rescue her, what was happening is that Anna had found a air pocket under the ice, so her airway, etc., wasn't filled with water, but she had this freezing cold mountain stream water flushing through, over her entire body. So she had very effective convective cooling, obviously quite a lot of radiation into that water as well from her body, and quite a lot of conduction. So in terms of thermoregulation mechanisms we're working on there, like this is probably one of the fastest ways you could cool something is pour a load of ice water over it, really, really fast. After about 40 minutes, she stopped moving, and then I think it took them about 80 minutes of being trapped under this 20 centimeter thick ice for her to be freed. When they managed to pull her out, I think there was 2 doctors from the rescue teams there, and they started CPR. She was flown then to Tromsø University Hospital, and I think she was flown there within the hour by a Sea King rescue helicopter, and when she got to hospital, her core body temperature was recorded at 13.7 degrees Celsius, which I believe is still the lowest recorded core temperature in an adult ever recorded for a survivable or a survivor, somebody to come back from that core temperature. So I believe the lead kind of doctor consultant on that day was a gentleman called Mads Gilbert. Both these people have come to speak at WEM conferences in the past, and essentially he led the team that hundreds of doctors and nurses and healthcare professionals, where they worked for 9 hours to kind of bring her back. She was put on ECMO, which is extracorporeal membrane oxygenation machine, which when you see one of these working, it's like a work of science fiction. It really is like modern medicine. To me, not just as a paramedic, but as a human being, seeing somebody's blood volume pumped out of their body to be warmed and then pumped back into them is just for me, it's one of the pinnacles of kind of medicine. It's fascinating. And so they use the ECMO machine to warm her blood outside the body, pop it back in, which is one of the most effective ways of rewarming somebody. And then her heart started to beat again. I think it was 10:15 that night, and I think the accident had happened about 6:30 or something that evening. So she'd been in cardiac arrest for 3-4 hours at that point, and then I think after a few days on a ventilator in ITU, she woke up, and after a few more kind of weeks, months in the hospital, kind of went back to kind of a full recovery. She had, I think, a little bit of peripheral neuropathy and paralysis and things, but recovered all those things fully and went back to work. Not too long later, I don't believe it was certainly within the next year. So to speak for how likely is this to work? Does this work 100% of the time? Do we get everybody back? I think that's kind of a multifactorial problem. Yes, you have a patient who's been cooled very rapidly with reasonable airway protection, and neuroprotection. So that hypothermia gives a good neuroprotective effect as well. So the brain's need for oxygen reduces significantly. I think a big part of this is decision making by the rescuers and the medical staff as well. So the things that the teams did to get her out, her friends called for help within about 10 minutes, which is a massive effect. We know that the earlier we get someone there, the better. The fact that the rescue helicopter was diverted from another job and was available has a big effect. And I think the willingness and the commitment of the hospital staff to commit so many staff and so much resources to this all plays a big effect. And I think there's a big human factor and a big kind of organizational factor there of the organizational willingness and the healthcare willingness to put resources into these patients. I think survival rates for severe hypothermic arrests are still about 10 to 30%, within that range, which is massively higher than your kind of standard out of hospital cardiac arrest. It's about 10% chance in the UK. And then again, that's for various reasons as well. I personally feel that number could be a lot higher, if we had better rates of bystander CPR, more defibrillators, and a better system set up. So we do have a better chance, potentially 1 in 3 chance of getting these patients back if we're doing things the right way.
So that's fantastic. And just a good synopsis of both that case and indeed the outcome. I think what we'll do is just look at the literature, indeed the empirical literature, and then pivot to look at the management of sudden cold water immersion. So I guess my question to Ben around the literature would be that it sort of points to less enthusiastic survival rates post-arrest from cold water submersion, both in the literature around cardiac arrest in pediatrics, Ben, but also within sort of this EC-CPR, so extracorporeal cardiopulmonary resuscitation, so putting these people on ECMO. Could you maybe speak to, indeed, maybe why the poor outcomes exist for poor cardiac arrest in the case literature when it's involving sudden cold water immersion, and indeed why it's also potentially not quite there in the literature yet for ECMO.
Yeah, absolutely. So the literature around cardiac arrest in pediatrics from cold water immersion, the first thing that there is to note is the fact that the numbers of patients that are reported in the literature are very low. So there are not massive case series of, thousands and thousands of these pediatric cold water cardiac arrest, thankfully. But we do know that drowning is, still the leading cause of death in ages 1 to 4, and the second highest cause in ages 1 to 16 in terms of death in children, and worldwide drowning is still a huge issue. And what we in the UK know is that the ages 1 to 4 tend to drown in baths. The slightly older children tend to have issues in bodies of open water, ponds, things like that. And as we kind of move through our teenage years, misadventure can be potentially a factor that affects how we have entered water in the first place. In the case of the outcome for pediatrics being quite poor, there's, I guess, many different factors that potentially affects it, and we can't say for definite exactly what the issues will be. So some of the potential factors are that you, as a child, have a large surface area to kind of body ratio, so you are going to cool quicker. You tend not to have as much insulation as a child, so you are more likely to cool quicker. You are less likely to have the ability to control your breathing and to have a calm response to that cold water immersion. You're less likely to have had training in how to self-rescue. So, there's big projects from the RNLI looking at, how to float, how to survive. And that hopefully is starting to filter through schools and communities, that actually, children have that better availability of knowledge of how to survive in water and how to self-rescue. Because as Jamie said, self-rescue and rescue by bystanders and parents is where the difference is made in these cases. In terms of, children having cold water immersion events, they potentially have as much chance as an adult of survival in the right circumstances. Unfortunately, the circumstances that they tend to find themselves in, they are probably doing something without the knowledge of adults. Potentially, there may be less people around when they're, when they are in a state of misadventure, and so the things that Jamie talks about in terms of the immediate kind of rescue and CPR and good quality things, we still know that the adults and bystanders are less likely to go to a child that looks to be in distress because of social norms. People will want to, but then may take a little while to get them into a position that they are willing to go and rescue others. In terms of the CPR for hypothermic arrest, one of the biggest issues, I guess, for us certainly in the UK, is actual availability of CPR. So, in Scotland, we have ECMO available in Aberdeen for adults and children, at the Children's Hospital in Glasgow, and I think also possibly in Edinburgh, ECMO is available. Obviously, there are alternatives in terms of cardiac bypass available in more places, but actually the centres are few and far between. And across England, there are specialist ECMO centres, but again, very few and far between. The availability of those services will vary in terms of time frame, in terms of who's available. We're not regularly accessing them. We know from a pre-hospital environment that the initial phase treatment is just so important. So if we kind of have a look at the two different kind of etiologies that we're sort of talking about. So the sudden cold water immersion, where the patients become cold over a short period of time, but they haven't necessarily drowned. They've not been inhaling water. Those patients need really good quality CPR, really good rewarming, and they need to be transported in cardiac arrest as safely as possible with all of the essential management done well. So good CPR, continuous CPR, good ventilation, optimized ventilation, ideally suctioning any secretions, potentially, if it's available, passing of NG tubes, to deflate the stomach, to reduce the risk of any regurgitation. And then, in terms of the drug therapy, following your guidelines, looking at your special kind of circumstance cardiac arrest guidelines for hypothermia, which again we can talk about in a short while. And with your drownings, the CPR is really important. Your oxygenation, your ventilation management, your suctioning is even more important. Whether you're using multiple suction devices, if you have got that regurgitation, if it's in your skill set and you are a seasoned provider with, the skills, the ability to be practicing regularly, intubation for these patients is beneficial. However, if not, it's important that you're ventilating in the most effective method for that patient, and potentially using two-person techniques for bag valve masking patients or using eye gels. When it comes to accessing CPR, so your ECMO, early communication is going to be key for these. So speaking to the hospital really early, if someone can break away during the pre-hospital phase, working out where the closest ECMO centre is, speaking to an A&E, potentially going to your nearest A&E with the pre-alert that this patient may be an ECMO candidate, and there may be pathways within your ambulance service, within your local health authority, where ECMO retrieval teams are able to come to the hospital that's closest to you, rather than you bypassing a load of hospitals to go somewhere really far away, but getting them, into a hospital to then have that specialist retrieval is probably far more important. In terms of warming, I think we'll probably talk about that in a lot more detail shortly. So from a pre-hospital point of view, really important. Primary, good quality CPR, all the essential skills done well, early consideration of ECMO and early communication of the circumstances of the cardiac arrest to the receiving centre. Time is absolutely something that will run away with you on these jobs, and the sooner you communicate with those specialist centres, the more likely you are to be able to access them. The appropriateness of those interventions will depend on the circumstances that the child or adult has had their cardiac arrest or their sudden cold water immersion event. But like I said, the key is doing those essential things well, transporting safely. You're probably going to need lots of people. This is going to be a people-intensive, work-intensive incident. You're going to want to have the best quality CPR at all times, so regular rotation, particularly if you're in a cold environment doing CPR. You are going to want to be rotating very regularly to keep that CPR the best as possible.
So just pivoting on to that, Ben, you've mentioned some key aspects of management there. Jamie, I wondered if you could give us some fundamentals from your perspective, maybe about sort of stripping clothes off, and indeed that conduction principle you were talking about earlier. So when you're approaching the either peri-arrest or indeed post-arrest hypothermic patient, what would you look to be doing for these patients?
So as always, it's the basics done well. So in your peri-arrest patient, in any patient really, especially those patients who are suffering traumatic injuries, we know that hypothermia combined with trauma produces the triage of death, and then makes them coagulopathic and worsens prognosis. If a patient becomes hypothermic in any part of their kind of patient journey, they will have longer stays in hospital. They're more susceptible to infections, and just have a bad time. So I think hypothermia and the impacts of hypothermia, especially in the NHS, is very underreported, because we know that pre-hospital temperature management isn't very accurate. People become hypothermic in hospital wards as well, for various reasons. So the basics done well is really important. So protecting them from the environment. And it's not just a case of turning up and putting a sleeping bag or a load of jackets over somebody. You need to insulate them from the floor as well. That conductive heat loss is really much more effective than the radiation out into the atmosphere. Removing wet clothing is really important as well. As somebody warms up and their core temperature comes up, that's going to start to warm their clothes as well. And then those clothes will start to dry out. And as they start to dry out, that water vapor is going to evaporate away from their skin and away from their clothes and take a lot of energy. Evaporation is the most effective way to lose heat, whether it's hot or it's cold. If you're wearing cold, wet clothes, you're going to cool a lot faster. As you're trying to warm your patient up, they're just not going to get any warmer. That's also why Scotland in the winter feels much colder than -30 in Canada. The water vapor is still in the air. It hits your face. Your face and your skin temperature evaporates the water vapor and makes you feel colder than that nice dry cold at kind of -30, where there is no water vapor in the air. There is the old myth that you lose the most of your heat through your head as well. And while it's important to cover the patient's head, you lose heat from wherever's uncovered. And if you've got pretty much everything covered, the next biggest place you're going to lose heat from is through breathing. So as you breathe in and out, you have to warm and humidify the air to be able to use it in your body and respiration. So using a buff or a face mask or some sort of balaclava kind of deal to kind of reduce that differential as well is gonna help massively too. So yeah, insulate the warm environment. Below kind of 30 degrees, you're going to need exogenous heat, so a source of heat which is not the patient and not you. There's no point in putting a person in a sleeping bag with them, because while they will get warm, you're going to get cold as well, and then you'll potentially have two patients on, and that's what we really don't need. So you kind of classify these in two or three classifications. So you've got external passive, so removing wet clothing is really, really important. Blankets, warm drinks are good if the patient can manage that. But if you throw a cup of tea into a cold bath, that doesn't warm it up. So you don't take too much in the fact that they're managing warm drinks, because it's probably not having that much effect, and you still need to do it in conjunction with everything else. And it's a multifactorial thing. So you can then look at external actives. So if you've got a forced air heater, where you can, use a bear hugger or some form of kind of heated blanket with warm air, or indeed convective warm air over the patient, is going to really help as well. And then into the more advanced kind of interventions, where we have internal active heating. So where we're ventilating them with warm air, warm humidified air. We're using warmed intravenous fluids. We can look at peritoneal body lavage, and then into things like ECPR, like Ben's talking about with the cardiopulmonary bypass and ECMO machines. Those things are going to be really effective. By far, obviously, the most effective is your is your ECMO machine. You're going to get a temperature increase of 1 to 2 degrees every 5 minutes. If you're doing it if it's really effective. But obviously that's reserved for patients who are in cardiac arrest as well. I think there's also a bit of a myth still around, well, I don't want to warm them up too quickly initially. Now, in my experience, I don't think, and this is anecdotally, I don't think that you can warm somebody up too quickly. I think when you look at the rate of warming on an ECMO machine and how we see it as really positive that we're getting 1 to 2 degrees every 5 minutes, you're not going to achieve that pre-hospital. You'd be lucky if you get 1 to 2 degrees by the time you get to hospital, unless you're doing stuff that's really, really effective and probably pretty invasive. So yeah, really effective thermoregulation care, really effective stewardship of those thermodynamics. And I always see the patient as a set of thermodynamics. What's making this patient cold, and how can I address that? And again, for the patient in cardiac arrest, it's applying, BLS and ALS as described in all the guidelines. Rewarming them as fast as possible. I think you could say that rewarming is probably the best antiarrhythmic thing you can do for this patient in cardiac arrest. And again, look for don't just tunnel vision into the hypothermic just because we're outside or it's cold or whatever. Look for comorbidities. Consider alternative diagnosis. Why is this person hypothermic? A lot of these patients, especially in the UK, the 20,000 hypothermic deaths a year, there is an impact from trauma and drugs and alcohol. And again, as Ben spoke to, definitely have that early thought that this is going to be a prolonged resuscitation with a multi resource requirement and multi-specialty input as well. This patient is going to require a lot of commitment and a lot of input from resources and clinicians to do these things, and you're going to have to be advocate for this patient as well. But yeah, basics done well. And just remembering that your chest compressions and your defibrillation are most important. Defibrillation is less effective in hypothermia, and we can do that up to. We're not going to try it until the patient reaches about 30 degrees, and then it's going to be 3 times, and then we're going to probably stop that. Pacing is generally ineffective, and I think the guidance says that you're not going to try pacing unless it's not going to be effective until normothermia is reached, and you're probably not going to. It might just be a sinus bradycardia, which is not going to get better unless we get warmer. And again, the kind of bottom line, and people have heard this the time and time again, is that they're not dead until they're warm and dead. So you can't really diagnose death until you've got a patient who has been rewarmed, has been managed well, had good ALS, and everybody's on the same page.
That's fantastic, Jeremy. A really good synopsis from the management of the pathology. So, Ben, just to you and indeed then to Jamie, have you got any salient take-home points for listeners who want to sort of effectively deal with this pathology?
Absolutely. So when you're managing your sudden cold water immersion patient, careful, gentle handling is really important. The management of kind of your defibrillation strategies changes, your management of your drug strategies and your pharmacological interventions changes. Do the essential things really well. Think about the fact that chest compression is harder in someone that is cold. It's potentially going to be a kind of a need for the person doing CPR to be changed more frequently. Think about the physiology and what it is that's happened to that patient and what they need to be able to combat those issues. I recently had a patient that had a hypothermic cardiac arrest, not from cold water immersion, but had CPR for 2 hours and 20 minutes. before getting ROSC, they were super, super unstable in flight. Any movement, any acceleration, deceleration hugely changed their kind of baseline physiology at the time. Their blood pressure was dropping, going up. Their response to their sedation and the drugs that they required to remain sedated post-ROSC was they needed more frequently, and they were essentially a very unstable patient. So it's really important that the kind of gentle handling, the gentle use of drugs to make sure that you're not the response was kind of very quick and very sudden to kind of the vasopressors, and so it's just about managing these patients really carefully whilst you're transporting them to a specialist centre, or if, like we've talked about, that communication very early with those specialist centres, with your places that can provide VA, ECMO, ECCPR. So if your patient's in cardiac arrest, getting them potentially to come to you. When you do get that ROSC, manage them really carefully, warm them aggressively, like Jamie says. In terms of that warming, so things like, warmed fluids is not available to everyone, certainly not in the pre-hospital environment. So if you suspect your patient is a hypothermic cardiac arrest, then in the pre-hospital environment, try and get hold of your local specialist care team, whether that be your critical care team or basics responders that may or may not have the ability to provide warmed fluids. In hospital, things like your warmed bladder lavage. So, all of these things potentially will help your patient. Think about the issues with hypothermia, so diuresis, so keep your patient hydrated. Fluid resuscitation is really important, particularly post-ROSC. And just when you're managing these patients, change your mindset. You're in this for the long haul. This is a patient that you're going to resuscitate and resuscitate and resuscitate to the best of your ability, to the best of your services ability. You're going to need people. You're going to need resources, and don't give up on them until, like Jamie says, they are warm and dead. All right. You potentially have an opportunity to do some incredible life-saving work.
So I think, especially in the cold water immersion patient, you are heavily at risk of being put into the same situation yourself as a rescuer. So that danger aspect and that risk management and that dynamic risk assessment of the situation is, for me, unless you're a specialist responder with training and the correct PPE and equipment, to really, really, really do your best not to enter the water, because you're going to be put yourself in the same position. And water is one of the most dangerous mediums that we come across, and it's one of the most common mediums. We kind of work around this stuff every day, and the risk of it is just astronomical. I think if you kind of produced a product and it had the same element of risk and took it on something like Dragon's Den, they would just tell you to get lost because you're going to end the world, basically. And I would just simplify hypothermia management, whether that is, especially in cold water immersion, but once they've been rescued and they're out of the rooms at the hot zone, even though it's cold, pre-hospital temperature measurement is poor, especially once they've been in the water. The ear canals will be cold because of that cold water as well, so you probably won't get an accurate core temperature. So just simplify it. The International Committee of Alpine Rescue now recommends that you just use your AVPU scale to kind of synergize with the stages of hypothermia. So if they're alert, they might be cold, stress, or mildly hypothermic as well. Alert to voice and just a bit kind of apathetic, you're starting to get into your moderate. And then responsive to pain, or indeed unresponsive, you're going into severely, like kind of deeply hypothermic, or indeed severely hypothermic cardiac arrest. And I would just keep it that simple. I echo Ben, warm aggressively, especially pre-hospitally. I've never ever been able to warm a patient too fast, and indeed mechanical CPR devices are really useful. Bring spare batteries. This is going to be for the long haul. And if you haven't got one of those and you're trying to move a patient, we can do intermittent CPR with 5 minutes on and 5 minutes moving, and then 5 minutes on and 5 minutes moving. But again, as in any other cardiac arrest, effective CPR is one of the most important aspects of this. eCPR is really, really effective. The literature says about 50% of patients survive, and most of them are expected to have a good neurological outcome. I kind of caveat that in that a lot of that data comes from mountainous regions where they are receiving patients who are from ski areas, who are young and fit, and probably would have better outcomes than with UK population generally. In terms of selecting patients for that and futility of the resuscitation, there's something called the HOPE score that is used, which looks at serum potassium. It's quite common in avalanche rescue and medicine these days. But I believe that potassium over 10, or indeed, severe trauma is probably considered futile at that point.
So from a prognostication perspective, could you both maybe indeed speak to any tools that exist that would help the clinician? Jamie, I know you mentioned the HOPE score. Ben, could you maybe expand on it?
Yeah, absolutely. So as Jamie said, the HOPE score's a useful tool for prognostication. So this is a large international collaborative project that was carried out by one of the university hospitals in Switzerland. And essentially it gives you a percentage score of how likely the patient is to survive based from 0 to 10. So the information that you need for your patient to be able to utilize the HOPE score, and it's a website which will be in the show notes. So your age and years, the sex of the patient, whether they're male or female, and then hypothermia either with asphyxia, so head fully covered by water or snow and in cardiac arrest extrication, or without asphyxia, so immersion, outdoor or indoor cold exposure. How long their CPR duration was in minutes, and their serum potassium. Their temperature scale, you select either Celsius or Fahrenheit, and then you put in your temperature. And then the website itself asks that if this is a real case, that you include an email address. However, you can use it without including your email address. So for instance, if our patient was, 57 years old, was a female, had no asphyxia, had 2 hours and 20 minutes of CPR with a serum potassium of 5.4 and a core temperature of 27.5, that would give us a predicted survival score. So the HOPE survival probability would be 34%. And it gives you that kind of idea of how well your patient's going to do. There's a couple of papers that the website links you to for the kind of derivation study and of the external validation study, and then also into the European Resuscitation Council guidelines that also advocates its use. This is a tool that is not necessarily going to be something you use in the pre-hospital environment, but in the in-hospital environment, this is a really useful tool. And it's something that I would imagine will be utilized or discussed if you're speaking to a ECMO specialist or a service that can provide your EC-CPR. The HOPE score is really useful. When otherwise looking and thinking about prognostication, I guess it's taking those individual parts and then using that kind of information together. So I guess the biggest difference is around that hypothermia with or without asphyxia. And then, taking that into account, you're hopefully able to utilize that wherever you may have this situation. But it's a useful tool to have in the toolbox.
Listen, guys, that's absolutely fantastic and a really good synopsis of both what's happening at the body level or physiological level, and indeed some of the management principles. So I just want to thank you for your time today and indeed your input. And we'll catch you soon again on the World Extreme Medicine podcast for another engaging episode. Many thanks. Thanks for listening to the episode. Please feel free to rate, review and subscribe on whichever platform you're listening to. Please also head over to the World Extreme Medicine website where you can find more engaging content on extreme medicine webinars and indeed the collection of courses from our global network, including humanitarian, disaster relief, expedition, space, military, tactical and performance medicine. Thanks again.